fantastic to be with all of you. I'm sorry to interrupt all the great discussions because that's a lot of why we gather in this amazing space. It is a rare opportunity at this crazy UN General Assembly week to get a chance to get off your feet and sit down and have something to eat and meet your colleagues. And I look around this room and I know the people following us online all over the world. This is a room and a group, an audience of people who have been working on these issues for a really long time. Many of you could be very well up on stage with me to have these discussions. So thank you for taking the time to be here on what I think is a really important topic. You know, the UN General Assembly week to me is a little bit like taking a European bus tour. Maybe some of you have done this with your families, where if it's Tuesday, it's Brussels. If it's Wednesday, it's Vienna. That's a little bit like UN General Assembly week. If it's 8 o'clock in the morning, you're at a breakfast about sustainable agriculture, and at 10 a.m., financial inclusion is the most important thing in the world. By noon, it's internet connectivity. And here at 2, we're talking about cancer. But why is cancer an issue that should be at the top of the agenda at this year's UN General Assembly? Why is it so important? I can tell you from our perspective at Devex, as journalists, we're always thinking about these quadrants, right? Is something important? Is it expected or unexpected? And if you're in that top quadrant, an issue that is unexpected but vitally important, that definitely gets our attention. And I think that's what this issue really is all about. It's unexpected because there's a misconception that cancer is a rich country disease, right? That is the way many people in the global health community still look at it. And it's wrong, as you'll hear much more about today. It's also important because the global cancer burden is rising. It's already 10 million annual deaths. It's an enormous burden. And there are preventable, many of those deaths are preventable. In fact, inexpensively preventable. In straightforward ways, there are solutions, but we're not living up to the promise of those solutions. So this is one of those issues that this week was made for, that this week was designed for, that we have to elevate while we have the attention of the world. So we are so proud and honored at Devex to get a chance to do that with our colleagues and partners at MSD and MSD for Mothers. And so with that, I want to bring up Marianne Etiebet, who is our partner in crime on all good things that happened this week. Hi, Marianne.
Thank you, Raj. Thank you so much, audience. And I'm so glad you brought up the point around cancer as a disease that affects all of us. And of those 10 million deaths, 70% of them are happening in low and middle income countries. And for vaccine preventable cancers like cervical cancer, it's 90% of the deaths that are happening in low and middle income countries. That's unacceptable, unacceptable. And so, Raj, we're not riding in a bus today. All of you are actually pushing that bus uphill. And we're going to have to rely on all of you to do that because, you know, as I said earlier today, it's going to take all of us. And so what is the discussion here today that you have come to participate in? It's about a discussion on how we take action together. And so you're going to hear about how we need to center patient voices in everything that we do, in how we do it, and how we assess whether we've been successful. We're going to talk about how it requires public-private partnerships to actually get to that end goal, that end destination of saving lives. And we're going to ask all of you at the end to think through and to commit to joining in pushing this bus to that finish line. So thank you, Raj.
That's right, and thank you so much. Dr. Marianne Etiebet, please join me in thanking her. And we're going to get started with sort of a fireside chat. We've got 2 colleagues and participants who are going to join us on stage, so please join me in welcoming them, Tamika Felder and Carmen Villar. Tamika, Carmen, come and join me.
I'm bringing a pillow.
Yes, it's a wise idea. These are big chairs. Well, we're starting where I think we should start, which is on centering patients' voices in this, right? It is so often that, especially at high-level convenings like this, that we think we have the answers. But if you don't talk to patients and understand what their actual needs are, we often miss the boat.
Absolutely.
Maybe we think we have a great technology, but years later we realize, boy, we weren't able to deploy that, and you talk to patients and you find out why. So that's where we're starting today. And Tamika Felder is the chief visionary and founder of an organization called Survivor. That's spelled C-E-R, Vivor. And we'll talk more about why. And Carmen Villar is the vice president of social business innovation at MSD. So it's great to have the two of you to have this discussion. Tamika, maybe we just start with your personal story. Like, you created this organization, Survivor, because you yourself are a survivor.
Yeah, so I created what I wish I would have had. So this was in 2001. There's so much that has been done in this space since then, but in 2001, and among the general public, we really weren't talking about cervical cancer. We weren't talking about the human papillomavirus. I mean, I think that's probably foreign to you all because you're so ingrained in it. But the reality is that we weren't having conversations with our girlfriends and whomever, like, girl, did you get that HPV shot? Or did you do this? Or did you make sure you get your paps? We weren't doing that. And so when it happened to me at age 25 and I lost my fertility, it came as a complete shock. You know, it's still one of those things. I was looking at this gorgeous view before we started, and I thought to myself, wow, I'm here. I can see another like skyline because I survived that. And so when I built my organization, and it didn't come immediately, I was sitting at work and I was thinking like, how can I do this? How can I get up every day and put cancer behind me like it didn't happen? And I couldn't do it. So I built what I wish I had. And I thought, okay, we're going to have little support groups. We're going to do awareness. Now we have ambassadors all over the world, and I'm proud of it. It's exhausting, but there's work to do. And thank you all for including the patient's voice, because as Dr. Noah Brewer says, that we have the data, but the patients bring the data to life.
So when this happened to you, you get the news. You really didn't have that community of patients to rely on.
No.
And I guess, Carmen, turning to you, why is it important now for you at MSD when you're thinking about how do we prevent these deaths? How do we elevate these issues? Why is it important to put the patients first and to build that kind of community that was lacking back in 2001?
And thank you, Tamika, so much for being here today and sharing your story. It really is an honor to have a patient in the room. So let's give it up again for Tamika. At MSD, we're a science-driven company, and that's really good. We want to make quality medicines and vaccines, and we want to make them available for people all over the world. The problem is if people don't know they need them, if people don't have access to them, if people don't understand the literature that goes along with those products, so that they could read and understand the side effects or the potential issues they might have taking those medications, then it's all for naught. And the only way that we can figure that out is by actually talking to people like Tamika. At MSD, we do have a group, a patient innovation group, that actually works with a lot of our patient advocacy groups. We do the same with our Merck for Mothers program, our MSD for Mothers program. But we also have set realistic, but I hope ambitious goals around how many people we can reach with our products. Now, a couple years ago, we set our first public goals, and we really didn't know what we were getting into in terms of how much we could actually achieve as a company. And we started by saying we want to reach 100 million new people with innovative access solutions, meaning not just here's our medicine, but if you don't have health insurance, let's help you figure out how to get it. If you live in some place where they don't have a dispensary, let's figure out how you can get it. Let's think about innovative solutions to work with you in communities for patients. And so we set this 100 million people reached goal, and we exceeded it by almost double in the first year. So now we're challenging ourselves to say, hey, what can we do? So we've more than doubled that goal. We're now at, instead of 100 million annually, we're talking about 350 million. But we can't just say this is innovative, go do it.
Yep.
We have to understand what's really going to help people like Tamika.
What's fascinating to me about that story is you're a science-based organization. I think lots of other similar companies like yours, when they use the word innovation, they're referring to the lab. And so you're trying to extend that concept of innovation, but out to approaches, whether it's the financing, the literature, the education of the patient, right? And bringing the same rigor around innovation to that kind of access work.
Yes.
Maybe you could just say a word about what it means in low and middle income countries in particular. Like why is this? Because I don't know where all that success happened, that those really big numbers, but what is the challenge particularly in low and middle income country settings?
Well, obviously it's different in every country, and I would say that's really important to understand what some of the challenges are. But we know that people have to travel far to get to a clinic or to see a provider, that sometimes when they get there, there's not anybody at the clinic that can actually help them. The medicines might not be available. If I helicopter up a little bit and think about some of the systems challenges that people might be facing in their own locality or their own country, it could be supply chain issues. It could be a medicine that we have manufactured requires cold chain, and the cold chain is unreliable. So how do we help people solve these very problems? You know, I once judged this contest of college students who were in a global health program, and they had to present these ideas about how they were going to work in XYZ country. And one group came in and did their presentation and talked about how they were going to get rid of maize or get rid of corn, and they were going to use sorghum. And I said, and I know a lot of people are trying to do that, so nothing disparaging on them. But I said, how do you know they're going to like it? How do you know they're going to eat it? How do we know people aren't going to have questions about our vaccines and our products? And how are we going to answer them? And how are we going to help them understand the pros and some of the cons? It's really important to interface with patients. It's really important to interface with local community organizations and governments to understand how best in those specific situations we can help them increase health access, but also health equity.
So Tamika, you work with a lot of patients now on exactly these issues.
Yes.
What do they tell you are the gaps? What are they feeling when it comes to these
They
questions?
absolutely want to be a part of the conversation. We know who the experts are, but we are the experts of our bodies, right? And so they want to be a part of the conversation. We want to remind you all behind every single thing that you do, they're patients, right? When we talk about centering the patient, that means talking to the patient, touching the patient, going where the patients live. Obviously, in every aspect, you can't do that, but you learn more when you talk to them and you find out religious backgrounds, you know, community backgrounds. Patients also want things to happen. One of the hardest things for me was a young mother who, she was terminal cervical cancer. And she ended up sharing with me that, you know, I'm happy that I'm going to be able to help someone coming behind me, but this won't help me. And even though it did give her a little bit more time. And so we as patients, we're not patient because we're looking at life or death. And so we're reminded that our voices matter, even when we're gut punched with whatever extenuating circumstances that we're going through because of our diagnosis. But I like to remind the patients that they have a voice. If they don't have it right then and there when they're going through treatment, you know, for the survivorship, for me, you know, my organization is about making my survivorship count. Why? Because I survived. I'm able to sit here with you all because I survived. And so it really is about making sure that the experience that I had matters, but it's not just my experience. It's who's stage 0, who's stage 4, who's metastatic reoccurrent, every single part of it.
Yeah. I think maybe the most important way we can really emphasize and underline to people what it means to be a survivor is through our special guests that we have. And maybe we can bring our special guest up on stage. Chayton.
So my legacy, what I realized throughout was that, you know, my story wasn't going to be the lives that I birthed because cervical cancer took that away. But through an exceptional gift from a fellow cervical cancer survivor who looks nothing like me, I got to be a mom. So this is my son, Chayton Lennox. And so having cancer was hard and it took a lot. And I don't want anyone to endure cancer. I had both of my parents endure it and countless family members. Various cancers have touched it. I have an aunt now that is going through a very hard time. He's like his mom. He loves a microphone. But this is my legacy. this is my legacy beyond cervical cancer. It is also truly a testament of sharing my voice. And I hope he has a future where he won't be touched by any HPV-related cancers at all.
Well, this is amazing. Please. The best panelist I've had all week, I can tell you that.
I'm not sure why I'm up here, actually.
Yeah.
'Cause we don't.
None of us are needed. But, and especially the story, what it shows about the survivorship community, right? That someone else said, here, I have an embryo, and is supporting your family. Like, that's an amazing, amazing
Who doesn't
story.
look anything like me at all. And that's also the beauty of it. Every time I think about the name of this, and, you know, really it is access, right? And equitable, and making sure that people don't fall through the cracks. And people fall through the cracks for various reasons. So, you know, one of my other cancer friends who survived testicular cancer, Johnny Emmerman, who co-founded Emmerman Angels, he's just fantastic. You know, one thing that he taught me, he was like, there are a lot of cracks in the foundation of this world that we live in. And if we all take one little crack, we don't have to take all of them, but if we start filling them in, what a mighty difference we'll make. So part of what I'm doing is filling in that patient access gap, right? And showing how you can share your powerful stories to make lasting change.
So, Carmen, as we're going forward with this event, and we started with patient voices for a reason, what is the key call to action you have for our next panel, for everyone here, for everyone well beyond this room, watching online or here at the rest of the General Assembly? What do you want them to take away? Besides
I
how
can't
cute this
top
little guy
this.
is.
This is kind of well. I'll say a couple things. One is, you know, last year my mom had breast cancer, and I remember, and you know, my mom was a teacher for all these years, and very, you know, knows how to navigate generally the health system. But through her cancer journey, it was so fractured. There were so many different parts of the cancer journey that she couldn't keep straight. And, you know, she's getting older. Where does she go? What does she do? When? Who? What about this kind of surgery or that kind of surgery? She was going to go into and have this surgery that was just going to be horrendous for her. Anyway, the bottom line was she kind of engaged the nurse case manager after I asked her if she had one. And she found out and she connected with them. And I think patient navigation, patient support, like we're seeing here with Tamika, is so, so important. So partnership, I'm going to say, Rob. Partnership. We support patient navigation programs with American Cancer Society. We work with City Cancer Challenge to make sure that there are cancer plans on the ground in localities. This is so, so critical. You know, we're not there. We don't necessarily know what those plans should look like or what that navigation should look like. But what we can do is support our partners to do the work and to help make sure that patients get what they need to get better, to thrive, and to have little ones just like this.
And I like to look at it as partners in purpose.
Thank you.
Yeah.
Yeah, that's right. I guess when you think about the community that Devex represents, that this General Assembly Week represents, what do you want to see people do more? Is this a funding question, Tamika? Like,
there's always a need for funds. There's always a need for funds, but there's always a need. You know, people have focus groups all the time. But if you're not taking the information from the focus groups and putting it into action, then you're doing a disservice. So if you're just checking off a box to say, I did my due diligence, I did a focus group, then are you really helping the patients? So that means that you are not focused. You're listening, but you're not engaging and acting upon that. And so that's where that comes in.
I would just say co-creating.
Yes.
We're looking more and more at not just talking to communities, but actually sitting down and putting pen to paper about what is it going to take to improve the situation we're both trying to address.
Yeah, there's this idea of human-centered design and development more broadly, and I think it's been catching hold, but it turns out it's hard because the way we work, many organizations and institutions have been structured really in a very top-down way. And what the two of you are talking about might sound in some ways obvious, but it's kind of radical, actually, because very few global health initiatives start from the patients, right? And if we want to get the kind of success you've already seen, Carmen, that is certainly something I'm taking away from this conversation. So please, everyone, join me in thanking this fantastic panel, especially this little panelist, Chayton.
Can I take you?
Of course, for a moment.
Can I take
Thank you all so much.
Oh, thank you. Another round of applause for them, please. All right, I want to ask our panelists to start making their way up on stage as I introduce you. Please come and join us. And please join me in welcoming Dr. Rana Hajay, Dr. Ansem Hennis, Christy McComb, and Isabel Mousse. Please join me. Okay, that is a tough act to follow, everyone. But we're going to try our best. So we went from talking about patients, and we're going to stay with this idea in mind through our discussion that patients matter. But we really want to think about what are the gaps to access to care. And in particular, we're thinking about low and middle income countries. What are those gaps? And maybe I can start with you, Christy, as we start to think this through. Because it is interesting, not in a good way, that there are more cases, the incidence of cancer is higher in high-income countries, but the death rate is double in low and middle-income countries. And the question is why? What is happening that is causing us to be in a position where we see that reality, and we understand, those of us in this room who work on issues of global health, that these inequities exist across just about every issue. But cancer, as I said at the very start, is a little bit of a surprising one. Not everybody is as tuned into it. So let me just mention for people who don't know, Christy McComb is the managing director for Global Capacity Development Patient Support at the American Cancer Society. And you work precisely on these access to care issues around the world. So please.
Yes, the team that I represent here today, thank you for having me and for inviting the American Cancer Society. But you also mentioned 10 million deaths per year from cancer, 70% of which are in low and middle income countries, so that equates to 7 million a year. And just to put that in perspective, I don't like to pit diseases against one another, but we've suffered 7 million deaths from COVID since the beginning of the pandemic. But we're annually in low and middle income countries losing 7 million a year. So this is really a huge issue. And to your point, why, if you have half the incidence, do you have double the mortality? The way we try to think about it and explain it at ACS is what we call leaks in the pipeline. So if you think about trying to move water through a pipe, but there are a bunch of holes in the pipe, you're not going to have, you're going to have a trickle by the end getting out on the other end of the pipe. So let's start from, we talked earlier about, thinking about that patient moving, and actually the individual, right? They're not yet a patient in the community, in a rural community, trying to access treatment. Do they know about cancer? Do they know about the signs and symptoms? Do they know how to prevent cancer? Do they know where to access vaccines? If they go to the primary health care facility, does that professional there understand the signs and symptoms? And are they able to move them through the system to get to that appropriate screening and diagnosis? Once they get there, do they have trained professionals? Do they have enough professionals, or are they in a long waiting line? How did they get there? Do they have transportation? If they have to spend time in that city, do they have a place to stay? If they do get diagnosed and have to go through treatment, were they even told that they have cancer? Were they given information about their treatment plan? Do they understand it to make the best decisions for them and their families? Do they have access? Does the health facility have access to the right medicines to be able to provide that treatment? There's just so many steps along this journey where patients can fall out, can leak out of the pipeline, and that's what's happening. So we have preventable cancers that aren't prevented, we have delays in treatment initiation, and we have really poor quality outcomes for cancer, and that's really kind of the unacceptable situation that we're dealing with today. And as you pointed out, with the increasing incidence, if we don't make changes to the systems that these patients are living through, we will continue to see really horrible numbers coming out of this. And it's think about the patient, but also think about the families who were impacted by this.
So let's pick off one of those challenging areas and move to you, Dr. Ansem. So Anselm Hennis is the director for the Department of Non-Communicable Diseases and Mental Health at the Pan American Health Organization, or PAHO. So, let's think about early detection in particular. What is the challenge there? You represent countries across Latin America and the Caribbean. What do you see as the early detection challenge? It should be on. Just go ahead and talk.
Hello.
Yeah.
Good. Thanks. Okay, so the whole issue of early detection, and I'm actually going to use the example of cervical cancer. The cervical cancer accounts for about 4% of all cancers globally. but in many countries of Latin America and the Caribbean, it's actually the #1 cancer. It is actually a disease of disparities. It tends to affect women who are ethnic minority women in their countries, impoverished women who are poor, who are undereducated, women who also have diseases like HIV, those who are marginalized and discriminated against. So it basically functions almost as a perfect storm for discrimination. So you have women on one side who are basically underserved and outside the health system to some extent. And then on the other side, you have a health system that doesn't work effectively. The example now with cervical cancer is that in terms of incidence, the incidence is about 6 per 10 to the 5 in North America. It's about 13 by 10 to the 5 in Central America and the Caribbean, and about 15 by 10 to the 5 in South America. That's the incidence. In terms of mortality, it's about 2 by 10 to the 5 in North America, about 8 by 10 to the 5 in the Caribbean, Central America, and about 10 to 10 to the 5 in South America. So the incidence,
both the incidence and the mortality is more than twice
and so what you're seeing now is that in North America, where the rates are lower and the mortality is lower, clearly the outcomes are better. So you're looking at a gradation in terms of socioeconomic indicators. And so this really highlights the whole issue of disparities. So North America has had programs that have used high quality screening and detection. They've used programs that are able to find patients, refer them appropriately for care, follow up, refer them to an integrated healthcare system approach. And that is the way that programs work. And you can see right away in terms of the incidence and the outcomes, it is linked to the quality of the programs. So when you have a program that does not provide access to women who are at highest risk, who need to be screened and detected early, then have access to results, and then are appropriately referred, and then have access to appropriate treatment in terms of surgery or radiotherapy or what have you, these are the outcomes that you get.
So you're providing technical support to countries, and when you're meeting with health ministers in the regions, where do you tell them to start?
Right, well, right, so clearly you're looking at programmatic issues, but then of course the issue of screening and early detection. Cervical cancer can be screened through Papa Nicolau smears, is the way it's gone in the past. We're trying to move countries towards HPV screening, high quality screening. Then of course, when people are diagnosed, you have to be able to refer them for appropriate care. So it's a whole structure. It looks at, so the system must have adequate governance. It must have trained healthcare providers. The contents of the program must allow people to be diagnosed and referred and screened, et cetera, as appropriate. So it's a whole structural entity based on the building blocks of a healthcare system. If any block is not adequately developed and established with adequate financing and education, et cetera, et cetera, et cetera, you're going to have failures. So here's a way that you can move programs that are not working well in countries to the model that we see of success in North America. And of course, you can vaccinate, which prevents people getting cervical cancer in the first place, which you heard from our earlier presenters.
And we'll talk more about that too, and maybe we can use that as a jumping off point for Dr. Rana Hajedo to join the discussion. You are Director of Program Management for the World Health Organization in the Eastern Mediterranean Regional Office, and you spent a whole career at the CDC. And I know that there are now cervical cancer targets from the WHO, 90, 70, 90. Maybe you can just tell us a bit about what those targets are and how are we doing? We've already heard that incidence of cancer in general is going up and the burden is growing in low and middle income countries. How are we doing on those targets?
Thank you very much, Raj, and good afternoon. Really, thank you for hosting this. This is actually one of my, really the topics that is closest to my heart, even though I'm trained as an infectious disease physician and epidemiologist, but especially being in the region and seeing the burden of non-communicable disease in general, cancer in particular, and all the premature mortality that the region suffers from, made me like a big convert to support efforts for prevention in general. So the global strategy for the 90-70-90 aims at vaccinating 90% of girls to be fully vaccinated with the HPV vaccine by the age of 15 years by 2030. 70% of the women to be actually screened by age 35 and then by age 45, and 90% of women who are identified to have a cervical cancer to be treated. So this is the 90, 70, 90. So basically, there is this global elimination strategy at WHO that has three main pillars. The first one is primary prevention, which is HPV vaccine. We all know that HPV vaccine is one of the most effective strategies, almost 95% effectiveness. We have countries that had almost completely stopped screening right now because they have such a widespread vaccination programs. Then the second pillar of the strategy is about screening and early detection, which we call basically secondary prevention. So at least if you could not prevent it the first stage with the vaccine, you try to do secondary prevention. And the third one is about reducing the suffering. Basically, as soon as they are diagnosed, then they have to be treated. So maybe at least you can prevent premature mortality, etc. So these are the three pillars. Overall, globally, the progress overall has been slow. I mean, it's not, and in our region in particular, it's even slower. We do have almost now 140 countries, I think, that have introduced the HPV vaccine globally, not in our region. I'd like to talk a little bit about our region
Please
because
do.
this is the region where we can fully illustrate the gaps. So the Eastern Mediterranean region, as we call it, covers about 22 countries. That basically almost all of North Africa, Middle East and North Africa, plus Pakistan, Afghanistan, and Iran. We have a population total of almost 900 million. In the whole region, we have only 3 countries that have introduced the vaccine so far. This is a vaccine that was approved in 2005. I remember very clearly. I was at CDC at the time when ACIP approved it. My daughter was 15. She didn't want to take it initially. She told me she was low risk. Next year, I gave it to her and her brother, even though at the time, CDC only or ACIP only approved it for girls. So we're talking 2005. My daughter now is 32. So 16, what is it now, almost 18 years later, 17 years later, the majority of girls in our region and many of the developing low-income, low-middle-income countries have not yet had this vaccine. A huge loss of opportunity. Really, really heartbreaking, because as an infectious disease person, I know, and I think the whole audience knows, how many cancers do we have that are preventable right now with vaccine? HPV and hepatitis cancer, because we give the hepatitis B vaccine. We've been giving it now for years. So only in the whole cancer world, two cancers are actually preventable with vaccine. And so far, we are still sitting and organizing meeting and debating in some regions whether they should be introduced or not, or whether they are cost-effective.
So in your region, when you have a meeting with the Minister of Health and you make this compelling case, help people understand what is the reason why they're saying no.
The most common, and these are really the gaps in our, why we are so delayed on the whole implementation of strategy. First, it's the healthcare infrastructure. The majority of the countries do not have adequate infrastructure to support actually full vaccine. It's not just the cost. It's the same. I mean, I'm a vaccine person by training as well. And with new vaccines, we have always faced issues with, the burden of disease, the cost effectiveness, the supply chain, the logistics, etc. So we need to strengthen systems. So that's one thing. On top of it, in countries where they are in emergency, like more than half, actually now, unfortunately, in our region with Morocco and Libya being hit so hard last week, 14 out of 22 countries in our region are in emergency, many of them long-term. When you are in emergency, preventing cancer or even treating cancer is not your priority. You have to make sure you have food, shelter, basic access to essential health services. So that's having emergencies and fragile health system is a major impediment for that. Lack of awareness, many of them don't even know. There are, of course, the cultural issues that we faced back here in the US as well, the vaccine and the sexual related issues. One of the last countries in our region, actually 3 countries only have introduced it now. We have Morocco, Saudi Arabia, the Kingdom of Saudi Arabia, and United Arab Emirates. Saudi Arabia, which is the site of holy Muslim sites in the region, introduced it as a cancer vaccine, as a vaccine against cancer, not a vaccine against the sexually transmitted infections. This is the right approach for communication and advocacy, and that's one of the big gaps in our region. And last but not least is data. again, like Carmen mentioned, we are WHO, we are a technical organization, we are evidence-based. We would like to have more data on burden of disease. Cancer registries in many of the countries are still relatively weak. And whatever you see in the systems is still relatively an underestimate of the actual burden of disease and definitely mortality, because many patients with cancer go undiagnosed.
I think it's very helpful background. Yeah, please. To why we are where we are in a situation where we have a preventable cancer, we have a vaccine that works, and it's really helpful. And let's think maybe now about where many of these patients are, and that's in cities. And a lot of the low and middle income countries are urbanizing rapidly. A lot of the burden is in cities. And so we have Isabel Mestres Mesa, who's the CEO of City Cancer Challenge Foundation, to bring to this conversation, Isabel, why you're focused on cities, and what is the initiative in general that you're leading?
Thank you. Thank you very much. And of course, I have to thank Devex and MSD for inviting us and bringing us all together so we can share know-how and make connections. So thank you so much. So yeah, City Cancer Challenge is a foundation. We're based in Geneva. It was spearheaded by the Union of International Cancer Control. And the idea was exactly, there's a lot of, we have targets, we know what good looks like, but we don't know how. There's a lot of evidence in high-income countries, but there's very, very little evidence on how to advance access to cancer care in context of LMIC countries. So we decided actually to take action. So where the action happens is in the ground, is at the community level. So we decided something that back then, 6 years ago, was a bit of a challenging for people to understand that we're actually going to be addressing cancer care from a city perspective, when normally everybody cancer care is a national discussion. Well, 5 years later now, we have a very robust model. We bring stakeholders that have a decision-making power on that city. So we work with national governments, regional government, and city governments, a multi-layer approach. We bring the directors of all the hospitals, both public and private, the university, the patient groups, the paying system, everybody to actually start. What is super important is bringing the whole community together and start getting data. What are those gaps across all cancer care from a systemic perspective? Because that's one of the biggest problems is there is no data on what are the gaps, what are the needs. So therefore, all investments are actually not going to the right places. So we generate the data to understand the gaps across the city, and then we take them through a very robust process of understanding what are, based on those gaps, what are the priorities, what's the roadmap for the city, and then we go and implement. So why cities? What we've learned from cities is that cities are a perfect ecosystem of action, because for cancer, there's no, I call it the minimum viable product. Cancer is so comprehensive, so complex, and it's comprehensive. You need radiotherapy. I cannot go to a rural area. So the minimum place I can go to address cancer care from a systemic perspective is the city. So for me, that's the community. And a patient doesn't navigate in one institution. A patient navigates across institutions, across labs, across systems. It's the whole system represents. So what we have seen is that by strengthening the city and talking what you were saying before, the environment. So we bring the data, and through the projects, we prioritize projects that set up the fundamentals, the guidelines, the protocols, the quality assurance from all those projects that people don't focus because there's so many silos. Like, I'm going to do screening for cervical cancer. I'm going to do this thing for breast cancer. I'm going to do this thing for radiotherapy. And then it's all a mismatch of things that are not making sense. So what we do is choose those projects that set the fundamentals. So then from there, there's the protocols, there's the guidelines, there's the standards, the norms that they need in order to then go deep, and we tackle all the health system strengthening pillars. And the best that we were not expecting is the national impact. Because this is a top-down, a bottom-up approach, we're bringing evidence on the policy that are weak, on the changes of normative that need to happen based on the real data and based on the healthcare workers. So then we're seeing a lot of change of national policies that is impacting not only the city, but the whole country.
Well, and a lot of national policymakers live in cities, and probably like this audience and like all our panelists, cancer affects almost everyone's family in some way. And so when you can show them, look at these access challenges we see even in your own community, if it doesn't work in cities, it's not going to work anywhere. give us an example, just what are some of the cities so people have an idea. Where are you working?
Yeah, so actually I have my regional directors here for Africa, Europe, and Latin America. So please, after, go and look for them. They're here, yellow, a very pink dress, and the leopard lady. So we are in Latin America, which she always says, I have the biggest region. We're in Mexico, in León, in Colombia, and Paraguay, Brazil, Argentina, and Peru. In Africa, we're in Ghana, Kenya, and Rwanda. In Europe, we are in Georgia, and in Asia, we are in Malaysia, Cambodia, and Myanmar. Sadly, we had to stop operations. And we're growing. We're now going to soon do a call for new cities in the next month. So we're going to be welcoming candidates from cities, and we're looking forward to that.
So thank you for that. Please. So Christy, maybe we can turn to you for this, because I think there's a real challenge at the heart of this that we've gotten into a little bit, but maybe you can unpack it more for us. So we heard from Rana in her region. You can imagine being torn between immediate, urgent needs, and some of those might be health, some might not be health related, but certainly many infectious diseases, which is what we often typically think of when it comes to low and middle income settings. Here we are talking about a preventable cancer, but you have to vaccinate now. You may not see the benefit for that for many years. Cancer in general can be expensive to treat because you have all these layers of screenings and diagnosis. And how do you think about balancing the need for an integrated, strong health system that could address cancer with what you must hear from health ministries, which is we've got this immediate urgent need, and there's all these vertically funded programs out there that are structured around those immediate needs. We know how to tap into those. How do we as a global health community unpack that challenge?
It's a good question. You know, I don't, in cancer, I'm not sure that there actually are a lot of vertically funded programs. So that's one thing we should acknowledge, is that a lot of countries are figuring this out on their own, whether or not we're assisting. But just to say, absolutely, we know the best buys in prevention. The information is out there, and that's one thing I like to say. You know, the one thing about cancer, it's in every country in the world. We as the American Cancer Society are celebrating our 110th anniversary this month. We've been around the block dealing with this. There's a lot of lessons that can be learned through collaboration and partnership, but we should focus on those best buys and prevention, but at the same time, we need to also support patients that are going through this cancer. Imagine if any one of us, if we were like, oh, sorry, you missed your prevention opportunity, but you have cancer. So we do have to make those hard decisions about how we allocate resources. And you know, there's a theory out there, a philosophy around cancer ground shot that's in contrast to the moonshot, which really says focus on those high impact, low cost interventions that we know work, and make sure that those are available in all the places that they're needed. That's a great investment that we can start today before we invest in too many high tech technologies that may only affect a few people, you know, at a marginal cost. So that's one thing. But when it comes to supporting patients, the work we lead at ACS is really, again, across the continuum, patient navigation. Really, most of the countries that we're working in, and including the United States, have very fractured healthcare systems. Patients need that support along that journey. And by supporting patients, we do reduce those disparities in outcomes. And also, we actually improve the experience of the healthcare workers and systems. Our experience in the last 5 years in Kenya and Uganda, as we introduce navigation in the largest national hospitals that are serving the majority of cancer patients, the majority of who live in deep poverty, is a complete transformation of the way cancer care is delivered and the way healthcare providers feel about the work that they're doing. It doesn't feel as chaotic. It doesn't feel as hopeless to be able to provide that. So I think we can't ignore the needs, but of course we have to start with what we can do to prevent cancer.
So Anselm, there was a Lancet report recently that called for extending universal health coverage to include cancer. And I wonder, across the region that you work in, Latin America and Caribbean, are you seeing national health plans accept cancer treatment as part of the national program? Those that are not, are there similar arguments for not doing it, as you heard from Rana?
Yes, the reality is this, cancers are complex. They're very, very expensive to manage. And we would like to see countries include cancer in universal health coverage. but there are limitations, and the bottom line is financing. But I think there are certainly things that we can do. As you said before, cervical cancer and hepatitis B and liver cancer are certainly cancers that can be eliminated. And I think these for sure must be incorporated. We can show that we can make success. I mean, cervical cancer is probably the first non-communicable disease which is a cancer that can be eliminated. So I think let us use what we can to make the progress that we can achieve. Cancers are subject to early detection, prevention, as we heard, through vaccination, treatment and palliation. And so there's much that we can do. I think we need to tackle those that we can make biggest inroads into. Breast cancer is another cancer that can be incorporated. Prostate cancer, the jury is out on that in terms of whether or not it's screening and treatment is the way forward in prostate cancer. I certainly would go and get my prostate cancer checks at my age, and given my own ethnic risk, etc. But those are more complex issues, but it's pretty straightforward for cervical cancer and liver cancer. So I think certainly let's find a way forward to incorporate those into programs. I think financing is an issue that must be tackled. The whole issue of health workforce, training at all levels. If you don't have programmatic approaches that work, you're not going to make any impact at all. The issue of access to medicines and technologies. And in that regard, the Pan American Health Organization has actually had a strategic fund and a revolving fund, the regional revolving funds, which allow us to procure medications, high-cost medications, or diagnostic technologies, including for cancer, at the best possible price, because a pool procurement accompanied by technical cooperation. And this makes a tremendous difference to universal health coverage and access for cancer therapies in the region of the Americas. And of course, information. Information for data, information for telementoring and training, information in terms of telemedicine for those in remote areas. So there are many components that can be incorporated into health systems to actually improve cancer outcomes detection and services.
You know, Rana, if I have someone on a panel like this from one of the vertical funds that we've just talked about, especially around infectious diseases, a decade ago they would have just focused on that disease area. Now they say we're doing health system strengthening, right? The narrative has shifted because there's a sense, and maybe COVID was a good example, that we can use the same platforms designed for HIV to be able to test for COVID when that pandemic arose. I wonder whether there's a similar narrative shift happening for cancer, or that should happen, to say, yes, it is, in Anselm's words, expensive and complex to treat, but there are elements of it, at least, certainly vaccine distribution, maybe some early detection and diagnosis, that overlap with other health system strengthening investments, and therefore should be seen as part of it and not a separate investment that has to be made. Do you feel like that transition is happening in the way we talk about, think about, and advocate for cancer care?
It is starting, but we need to do a lot more. So, for cancer prevention, at least for vaccines, of course, Gavi, the Global Alliance and Vaccine Initiative, is moving away from the vertical vaccine initiatives. I mean, 20 years ago, I was leading a team on Hib vaccine introduction, and we introduced Hib vaccine in 72 countries, low middle income countries. But Gavi has moved since. They have moved away from this vertical approach to more of a cross-cutting approach, strengthening health systems, immunization system, etc. On the cancer side, I don't see this yet happening. However, this week we are here for the UN General Assembly. Tomorrow and Thursday, there's the high-level meeting on universal health coverage, and the basic, it's PHC, primary strengthening primary health care towards broadening the access of universal health coverage. So we are trying to, through the strengthening of primary health care, we are working on an integrated approach where cancer care will be integrated as part of primary health care. maybe not at the first level, they're secondary, etc. But, what we see now, for example, is rarely cancer medications are part of what we call the essential service package. They're not, because they're very expensive, and we need other initiatives in order to make sure the cancer medications are accessible. There are generics. There's similar processes to what we have done with the antiretroviral therapy, for example, for HIV. It's not. Of course, it's not as simple because the technologies are different, et cetera, and the vaccine, the rates are relatively less prevalence. But what we are doing in our region, so we developed our own regional strategy that in addition to the 3 pillars I talked about, we are focusing on 2 what we call enabling functions. One of them is health system strengthening by supporting stronger primary health care. And I just want to make a note here because sometimes you throw the baby with the bathwater. By going away, it's a really very tricky balance to go away from very vertical programs to strengthening systems, but you should not lose focus on priority public health programs. But that depends on the country. Each country has its own context, and they should adjust their policies and their primary health care accordingly. The second major area that's really important is communication and advocacy. So we are working very closely with the countries to have champions, to increase awareness and advocacy for not just for vaccine, but also for screening, for especially screening. I was shocked, I'll tell you. About 3 weeks ago, we were in a meeting in a mission in Pakistan, our largest country, to support their vaccine program. They've actually done well in terms of increasing their overall vaccine coverage. And one of the big things we were pushing for was really the HPV awareness. We had a big meeting in Karachi, which is the province of Sindh, one of their largest. The meeting included professors of OBGYN from many of the university, both in Karachi, in Lahore, which is the other province, Punjab. I was shocked when one of the professors, who was one of the oldest professors, got up and she looked at me and she said, none of us here, women professors, most of them, none of us had ever had screening for cervical cancer. None of them. They don't even have the basic screening programs. And that's one of the reasons, not because, of course, vaccines, some people say for vaccine advocates, everything looks, if you are a hammer, everything looks like a nail. They're not the only solution. Of course, we need to work on the other pillars. But for countries where access to screening, to treatment is so limited, prevention is our main hope.
Yeah.
So we are working with these countries, at least the ones, the Gavi eligible countries, and we have 7 in our region that are Gavi eligible. They get the vaccine at a relatively, really very low cost because Gavi subsidized the vaccine. None of the 7 countries in our region yet have made the decision even to submit an application to Gavi. So we are working with them on that by supporting their, the process of developing, because you need all the elements in order to put together a good application, etc. So technical assistance from our side, community engagement, and youth. I think this is the future. I was so happy. I was going to say, when I saw Tamika, right? Sorry, Tamika is starting really early with her son. But I think the future is in young women having a strong voice, asking for their rights. Yesterday there was a meeting. We started UNGA with a meeting at UNICEF on accelerating the promise for maternal, women and child health initiatives. And there was a young woman from Mozambique, I think, who was just amazing. She grew up in a very, low resource setting, and she was so inspiring, so powerful. This is the future. We need more community engagement. We need to empower our youth and our young women to ask for this as part of their essential rights, access to health.
So we've run out of time, but I don't want to end without a real call to action. And Isabel, I want to turn to you for that, if I can. Because you work with and represent so many people who are out there seeking cancer care. What do you want this community, this group to leave with as we go on to all the other sessions at the UN General Assembly, many of which will not have anything to do with cancer? How do we take what we learned here and bring it there?
Thank you for giving me this opportunity. So actually, sometimes when I'm in these forums, I feel a bit uncomfortable myself because I'm not the one that should be here speaking. But I'm the CEO, and sometimes that I get the invitation. But we need to bring that local voice. What I would like all of you to take, and this is something that brings us very much closer with MSD. We're very in that this localization agenda. It's the power has to be in the people that are in the ground, not other ways. And if we want the power to be down and they have to be the ones driving change in their own system, we have to be patient. I need to share something that is very illustrative. One of the things we get support from MSD is to build the local capacity on data management, on leadership skills, on project management. They need that skills if we want them to drive the change. The problem is that the international community has so little patience that they pressure us so much for results from the donor perspective that we end up jumping in and hiring consultants to meet those deadlines. So we have to be much more patient and bring the power to them to change it, and in whatever conditions they have. Like sometimes I've seen donors asking this complex series of change. Just get them to send you a paper with the idea. Exactly. Don't ask them this, because if not, again, it's going to be always going to be our evidence on their space, and they're not going to be able to drive change. So please empower, not empowerment, it's power for them and patience from the international community.
Well, please join me in thanking this fantastic panel. Thank you so much for leading us in this discussion today, really. Thank you. Thank you so much. And as we just close here, I want to thank all of you in this room and following us online. I'll pick up on something Carmen said in the first conversation, that so often in these kinds of rooms, when we talk about innovation, we refer to what happens in the lab. And really, we need to think about innovation in terms of every step in that patient's journey. And when we do that, and to pick up on Christy's point about finding ground shots, finding things that we know work, like vaccines that prevent cervical cancer, and finding those opportunities to use the tools we already have, there are enormous opportunities in a week when we're thinking about how the world is in many ways spinning out of control, things are getting worse. There are opportunities to reverse some of those negative trends. They're right in front of us. And so it's a real pleasure to bring a discussion like this, such an important one, to all of you with our partners at MSD. Thank you so much for being here.